discussing retention today. So thank you very much for sharing that. And for those who are just joining, please use the chat box to share with us who you are, where you're joining from today, and what you as an individual really enjoy most about your current role, and share that with all participants.
So Elizabeth, as we're just waiting for people to join us, what do you appreciate or enjoy in your current role?
Everything, Zoe. No, not really everything, but just coming in and just seeing my fellow colleagues interacting every day and getting on with what we really need to do. But over the last year, I've really enjoyed just stopping and talking to my colleagues in the corridors or as we walk in from the tube station. Just catching up with each other has really been different in the last 12 months. What do you enjoy, Zoe?
What do I enjoy? I enjoy people. I love talking, I love sharing, I love learning. I love working with lots of different people. I'm a people person, so I just really appreciate my colleagues and the work that we do together. So that's what I really like. So please do share with us in the chat box what you enjoy about your role, your current role, or what you appreciate about your role.
Welcome to Charlotte. Thank you for sharing. Welcome to Francis from Leeds. Got a number of people joining us. Lots going on in the chat box. Please share with us what you really enjoy about your role, but also who you are and where you're joining from today. And share that, send that to all the participants.
So if you're joining us, welcome, and we'll be on YouTube live as well. So welcome if you're on YouTube today. Welcome to this session, and if you want to stay in touch after this session, then please do keep an eye on the Horizons website where you've got the details for today's webinar, and also have a little look on Twitter. So Caring for NHS People, that's the number 4. NHS People, we've got Project M, which is all about supporting managers within health and care. Lots and lots of support offers on the websites as well. There's 2 websites now. So england.nhs.uk/people and also people.nhs.uk. Please do have a look at those.
Welcome to Jane. Welcome to Lillian from West London. Lots of people joining us. Welcome. I think that was just a message saying a message on my screen. But welcome to Monica. Lots of people joining us. Michelle. As you join, please share with us who you are, where you're joining from, and what you really enjoy about your current role, and send that to all participants.
So we've got Sarah Wilson in the chat. Hello, Sarah. Sarah's saying that she's the lead community matron at Sheffield Teaching Hospitals, and she enjoys supporting nurses to do their job, ensuring they feel supported and have what they need to do their job. Please do share in the chat box. We'll be starting very shortly, and while we wait for 4 o'clock, then please do say hello in the chat box. Say who you are, where you are today. What do you as an individual enjoy or appreciate most about your current role, and send it to all participants. So I'm going to introduce John Drew shortly. And John, I'm going to ask you this question when you start. What do you as an individual enjoy and appreciate most about your current role? So that's my leading question for you. So welcome if you're on YouTube, and welcome if you're on Zoom with us today. Please do keep using the chat box on both platforms and let us know what you appreciate most about your current role. We can see that we've got lots and lots in the chat box about what people are enjoying or appreciating in their current role. So, as we hit the clock, welcome everybody. Welcome to this NHS England and NHS Improvement monthly national community meeting, which is all about supporting the health and wellbeing of NHS people during and beyond the COVID-19 response. Today, we're talking about retaining our NHS people beyond the pandemic. And to me, this means lots about belonging. It means inclusion. It means so much about wellbeing. I'm going to be hearing lots and lots about that today. So welcome to this session. As I said, I'm going to hand over to John Drew now. John's the Director of Staff Experience and Engagement here at NHS England and Improvement. So John, what do you really enjoy in your role?
Well, I think I enjoy being able to make a difference on the topics that I care about the most. And, you know, I think that it may sound strange, but I think we've got a lot to be thankful to the pandemic for giving us back a focus on people and looking after people. So I think that means that we've got lots of attention. We've actually got lots of resources and funding that we, you know, it doesn't feel great to say this, but I'm not sure we would have had on these topics if it hadn't been for the pandemic. So, you know, I feel, as I hope we all do, that we've got an amazing opportunity right now to really change the conditions in a lasting way for how it feels to work in the NHS, you know, the culture, not just health and wellbeing, but that as an important component part of lots of other things, which is actually what we're going to be talking about today with the focus on retention. So I think it's that.
Thanks, John. And why do you think this why is this such an important topic at the moment?
Do you mean health and wellbeing or retention?
Both, yeah.
Well, I think because people are going to be reflecting, aren't they, and taking stock of what matters to them. I think that for people that have waited for a holiday and maybe having one annual leave in the summer, that is often a time that we reflect. And then at the end of it, you kind of wonder, do you look forward to going back to work or are you dreading it? So I think that it's a key moment, I would say, for people to make a lot of those decisions. And I think there's also a sense that actually people are still, you know, carrying a level of tiredness. I feel I am. So this idea of recovery is easy to say, but it's not straightforward to achieve. I think it does require, you know, a proper break. People have said to me that, you know, they have a week off, even it's not enough. So I think that you know, that whole aspect of feeling a bit worn out, also maybe taking stock, reflecting on the experience, having a break, you know, there's lots in the mix there, and people will be making choices, and we want them to choose to stay, feeling positive about, you know, the outlook, rather than, you know, choosing to stay and living with a set of difficulties that kind of hold them back. We want them to stay and feel like there's there's hope, there's a kind of positive future to look forward to.
And as we open the session today, John, is there anything else that you'd like to share with the community before we launch into our speakers today?
Well, I think you've managed to extract quite a lot out of me already. So what I would do is just share a few reflections from a call earlier today with the SROs, the senior responsible officers for the whole system health and wellbeing pilots that we're running. And there were three things that came out of that I thought were worth passing on. So one is that one of them commented that it's quite a crowded space now, health and wellbeing. So I think there's something for us all, which is how do we try and simplify it so that people get the simple messages, they know how to access support, rather than feeling like there's almost so much going on, I can't work out where to start. Mm-hmm. So, you know, I think we can all be well motivated in almost putting more things out there. But I think if we think back from the point of view of the people we're trying to help, how do we keep it simple would be one thing. There was something then still about behaviour, which is another SRO said that she still talks to a lot of people that say I'm fine, and that's partly perhaps a British thing, but we've kind of we have been talking for a while about resilience, which I think there's now a bit of a reaction against. That resilience shouldn't mean just kind of suck it up and deal with it. That's not a good response to the pressures people are under. So there's something about how do we continue to make it okay to seek help, and to say actually that's a braver thing to do than to say you're fine. Mm-hmm. And then the third thing for me was one of the SROs, and I think a couple picked up on this, recognise that there's a shift towards embedding health and wellbeing in teams, that we've gone perhaps from this being very individually based to how do we make sure that this is happening in teams, which I think makes it more embedded and more sustainable. And there's, if you don't know the data, the mental health hubs that have been established have now been called on 11,000 times. 55% of that has been individuals, but actually 45% has been teams or groups seeking help of some sort, which I thought was really interesting. It's not what I would have expected at the beginning, but I actually think that's also very positive, because there is more natural resilience and mutual support within a team. So I think that's another theme for us to think about in retention as well. How do we help teams to be healthy and supportive, so that we're delivering the people promise at a team level as well as an NHS and an organisational level?
Mm-hmm. That's great. That's
probably more than enough from me, so I'll hand back to you.
Thanks, always great, John. And you've hinted at our next wellbeing webinar, which is all about mental health and mental health hubs and health and wellbeing. So thanks for that, and thank you for opening the session today. So you all know these sessions, we're going to support each other. We're going to be sharing activities, and we want you to keep connecting with each other. Just thought we'd let you know about these sessions. Now, this is our 25th session. You can see how many participants we've had there, over 8,000, lots and lots of views. So I just wanted to remind you that if you did miss any of the past sessions, then head over to the Horizons website and you'll be able to look at all the previous sessions. Lots and lots of topics have been covered. So this is our agenda for today. So we're going to have a few national overviews. Steve Lee and Chris are going to give us some national overviews of our programmes. We've got Dr. Andrew Wayman with us, who's going to be talking about NHS staff retention and the research around that. And we've got Guy and Katie, who are going to be giving a local example about North Bristol Trust, and then we'll close in our usual fashion.
And on the team today, you've got me and Zoe, who are your co-facilitators. I am Elizabeth Nyawade, and I am currently the Director of Workforce here at St. George's NHS Foundation Trust. From our speakers, you've already heard from John. We've also got Steve Lee, Kritz, and I'm going to mispronounce your surname now, Zikiti, and then we've got Dr. Andrew Wayman, and we've also got Guy Dixon and Dr. Katie Egan. And behind the scenes supporting the session today, we've got Paul, who is our technical host, and we've got Michelle and Laura, who are our chat box facilitators today. And we've got Ian and Lindsay on YouTube, and Lee is on social media today. Thank you.
So we're going to
go on, Zoe.
Sorry, Liz, this was your bit, I think. But we're going to hand over to Steve. We won't fight over you. So Steve's interim head of health and wellbeing at NHS England and Improvement. Over to you, Steve.
Thanks very much, Zoe, and thank you for having us along today to give you a brief overview of where we've got to with the health and wellbeing programme. So if I could get the first slide, thank you. So just to remind people that there are 3 priority areas for the coming year. The first is that we need to help ensure that wellbeing guardians and boards feel supported in their role and that they champion health and wellbeing consistently within organisations. A development that I'll unpack a bit further in the next couple of slides is that we've worked with the Thomas Ashton Institute, a collaboration between a Health and Safety Executive and the University of Manchester, to develop a dashboard to help assess health and wellbeing performance and to inform preventive interventions. We also, as John's mentioned, kind of the importance around teams and individuals and their line managers to have ownership of health and wellbeing, and that they have compassionate, regular health and wellbeing conversations. Again, I'll provide an update a bit later in the presentation. And the final area, John has mentioned again, the mental health hubs that are on stream now and are receiving a number of queries, but coupled and allied to that is work that we're doing on occupational health that needs to become an integral part of a preventive approach to health and wellbeing, while also ensuring that we have a focus on people recovery. If I could get the next slide, please.
I think it's a little delay.
On your end.
Yes, it's my end.
That's okay.
Jumped up.
Okay, and this is going to be very brief, so that's okay. We'll make up some time. But just to show you the development that we've had in terms of creating a dashboard to give organisations an insight on health and wellbeing. And this is kind of the opening slide for, when you access the model health system. Here's where it takes you to. You can see the health and wellbeing compartment there that runs alongside equality, diversity and inclusion and retention. If I could get the next slide, please. Retention.
So I live in a very rural at the moment. So has it arrived yet for you?
It's arrived. So okay, so where I've got 6 minutes. I'm going to go at speed, Zoe. So just to kind of unpack that a bit more in terms of that wellbeing compartment on the model health system, there are 6 main areas that we're looking at, both lead and lag indicators. So typically on health and wellbeing, organisations may default to looking at lag indicators, things like sickness absence, things like presenteeism, almost, kind of dealing with things when they're kind of past the point of no return in terms of, when people have gone off sick or a negative thing has happened. Whereas what we're really keen to do is balance that with some of those more lead indicators, things that organisations have a say over, have a degree of control over, and that they can influence. The Thomas Ashton Institute have kind of used existing indicators taken from the staff survey, the pulse survey, and mapped those across to those lead and lag indicators that give you an insight as to how your organisation is performing. We can move on to the next one. So thank you. So this gives you an indication of what, when you've accessed the model health system, you've tapped into one of those 6 dimensions that I shared earlier. This is what you're presented with in terms of your data, so you can have a look at how you're performing against that dimension. On this one, it's around psychological safety. But you can also see how you compare with your peer group and across the piece, really, to see where you are. But more importantly than that, it helps you as a guardian or a board to kind of query, where are we? What does this look like? How do we get behind the data to validate and verify this is where we are? Who else can we talk to who seems to be performing well to see what they've got in place, and can we replicate that within our organisation? So the whole drive behind this is to get the guardians and the boards to kind of think about health and wellbeing in the round, to balance their kind of interventions against, not just looking at sickness absence, but also looking at the things that they can influence upstream to yield downstream benefits. We can move on to the next one, please. Just briefly on health and wellbeing conversations, colleagues will be aware that we've already issued guidance on health and wellbeing conversations and talking heads videos from colleagues who've had successful conversations. Just to say that there's some additional training for colleagues to help build confidence about holding conversations aimed at line managers and others. We're rolling out a training program, but there'll also be train the trainer modules too to help we ensure sustainability. If we can move to the next one. And just a final one for me for those 3 areas that we're really having a focus on for this year is around occupational health. And we've worked with Dr. Steve Borman, the Faculty of Occupational Medicine, Society of Occupational Medicine and others to help us map out what we need to do to ensure that occupational health becomes an integral part of a preventive health and wellbeing approach. So there you'll see a number of drivers that we're working on, which includes things around the occupational health brand and positioning of occupational health, how we look at increasing the focus on proactivity within that service provision. So moving away from in parts, not, this isn't kind of a blanket kind of statement I'm making here, but in parts, how do we ensure that the occupational health provides that consistent service, as opposed to being seen as one of those lag indicator measures, when you're looking at just number of referrals, to a service that can really help you kind of get behind the data, can help you look at, kind of what interventions can we put in place, say, for example, around work stress, and what can we expect to see over time. We'll be launching on Friday, so this is kind of a bit of a heads up that this is coming out in terms of looking at those areas that we'll be pursuing over coming months. But taken as a whole, we hope that what we'll deliver in time is that more kind of uniform service provision that has a much stronger focus on prevention, is much more integrated into an organisation's approach. We can see there's an awful lot of value in getting this right. The final thing to say as well, and there's not a slide on this one, is that in addition, we're providing support to health and wellbeing champions who can help colleagues signpost to the right services for them. We held a really great launch event yesterday where we had 300 people turn up who are either existing champions or who wanted to be champions, and we'll continue to do that as well. Continue to focus on those three areas, but if there are any other areas of provision or where we need to provide an offer, we'll respond to that too. So that's a really quick whistle-stop tour, Zoe, but hopefully of use.
It was a brilliant whistle-stop tour. Thanks, Steve, as always. And all the slides will be available, and we'll pop some links into the chat box as well. So we're going to talk in depth now about retention, but we want to get a few ideas from yourselves as well about what retention means to you, what it's like in your organisation, what are your organisations doing. So I'd love you, if you can, to go to Menti. So whether you're on Zoom or you're on YouTube, please head over to Menti. So you can do this by going to menti.com and using the code that you can see there on the screen, or you can use the hyperlinks which have just been added into your chat boxes, or you can use the QR code. So to use the QR code, you just need to go onto your camera app and then just scan the QR code, which I will do now as well. So the first question that we have for you is, how high is retention on your organisation's priorities? How high is retention on your organisation's priorities? And you can go from low to high on there as well. So, Lindsay, shall we share the results of this one? And Lindsay, you're just on mute at the moment, but it'd be great if we could share the results, and we'll have a look at this one, and we'll have a look at the next question as well. Thanks, Lindsay. So we've got a selection there across. So some people are saying very high, but there's quite a few in the middle who either are high or don't know, and there's a couple at low at the moment, and 52 people have answered that question. Thank you. Let's go on to our next question. So our next question, you should see it if you press refresh on your screen. So what's enjoyable to you on a personal level working in the NHS? Let us know what is enjoyable for you on a personal level. I'm going to complete this as well. And we should see some things coming up now. So we've got deeply rewarding. You can see these on your screen on both YouTube and in Zoom. Being appreciated, talking with colleagues. We've got the range of work, working with lovely staff. We've got making a difference. Yeah, so lots and lots coming in there. Keep coming them through, keep adding to that as well. And I'll just finish mine as well. So feeling part of a national organisation, helping people, colleagues, the people. That's coming up loads about people. And we've got one final question that we're just going to move on to before we go to Chris for the national update. So the next question is, what's the one thing your organisation is doing or could do to best support people to stay in the NHS during these challenging times? So I'll just repeat that, which is what's the one thing that your organisation is doing or could do to best support people to stay in the NHS during these challenging times? And they're coming through now. So we've got open and meaningful conversations, talking and engage, act and listen, agile working, you can see them all coming through there, retention programs, listening is coming through a lot as well, listening, psychological safety. So I'm going to keep that open. We're going to go back to the slides now, but I'm going to keep that open, and please do keep adding to that throughout the session as we do. So I'm going to ask my colleague Vanessa if she could just share the slides for us. Hopefully there'll be a better connection than mine here. So I'm now handing over to Chris. Chris, could you give us an update?
Brilliant. Zoe, thank you very much, and good to see everyone online. I'm going to provide a bit of information on our retention program. My name is Chris Tsikiti, Head of Programs, Transformation and Delivery in the People Directorate, and I lead the National Retention Program. Next slide, please. So just quickly, I've got a few minutes just to talk a bit about what we're doing in the National Retention Program. Most people tend to think, why, the program, and as you can see on the slide, John started very well talking about people. Our program is all about people. We want to focus on our NHS people. One thing we are clear is we will always need our people, either today, tomorrow, and always, we'll always need our people, our NHS people. So our program is really focusing on people. We want our people to stay and stay well. We want to have our NHS people to have an improved staff experience, because it has a massive, massive positive impact on patient care. NHS is massive, it's big. We've got more than 1.3 million people working in the NHS. And our program, as it launched in summer of 2020, our focus was we want to support employers. We want to support managers to value, to support and retain our staff. If we can retain our staff and make sure, they stay well as well, that would be a success story for us all. The other thing I'll mention is the program obviously is focusing also on the government manifesto commitment of retaining 50,000 more nurses, and we are part of that program. Some of the work we're doing around the program, it's all related to everything we have said in the people plan. That's why you would see the 4 pillars of the people plan around looking after our people, growing for the future, belonging in the NHS, and new ways of working. So this is not separate. Actually, the people plan enables us to retain our people. And we will hear more people talking about the people promise. It's all interrelated. If we can deliver, I was saying to other colleagues yesterday, if we can deliver the people promise, then we would have done well by our NHS staff. So we want to respond to that. We know it's been a challenging time the last 15 months. We know what systems and trust and our colleagues are working frontline have been going through, the challenges we have had to encounter through the pandemic. And we want to make sure we respond to that. We want to make sure we learn from all those experiences. We rely on data. We want to use the evidence out there. We gather a lot of intelligence from colleagues who are working frontline about what's important, so that we can have targeted interventions to respond to local needs. We use the staff survey, and some of you have seen the results. We use the ESR data. We use some of the provider returns to actually inform our approach to retention. Like I said about the pandemic, we had colleagues talking about health and well-being, because that's critical, how we respond in supporting people from a compassionate point of view, and supporting organizations to make sure actually we've got that compassionate leadership, we've got an inclusive leadership, we incorporate, the intel coming through from local systems. Next slide, please. I thought it would be good to touch base on some of the work we have done in the last financial year, in trying to promote retention work and in trying to promote the retention program. We launched our retention hub that most systems and organizations have got access to. This is just a place where you can find some NHS EI web pages around case studies, around guidance, around some practical tools in terms of some of the work you need to do to improve the staff experience and retain our NHS people. And we've got a link, and I know the team can share the link for the retention hub for those colleagues who haven't yet accessed the retention hub. And we cover all of the 7 people promises as well. We are working with at least 10 ICSs or systems which cover 77 trusts, just supporting people to do a bit of diagnosis using the data on some of the reasons, why people end up leaving the NHS, and not just focusing on why people leave the NHS, but also focusing on what is it we need to do to enable people to remain. What makes people stay? And we are really, really, keen to hear more about what can we do to enable people to stay. So we run a 90-day improvement cycle with systems to understand local needs and to help them to have an improvement action plan that will address some of the gaps identified by the diagnosis process. And we are working with those, 10 ICS systems. We are still planning to pick up some more ICS systems to support as we progress with the program. The other piece of work we are really, really excited about is the generational program. This is really focusing on different generations. One thing now I know, now that I'm a parent, is when I started my career as a mental health nurse, my needs were different. As a young man, I was, in my early 20s. I didn't have any responsibilities, and my needs were different. And as I grew up and became a parent, my needs also changed because I had other responsibilities, because I've got kids, and working flexibly became a key issue for me. And I know colleagues then who are 50 plus in the late stages of their career. They've got different needs they need in order for them to do well for the NHS. So our work is trying to respond to those needs, for different, groups of our staff. So we'll continue doing some work around that. The other bit to think about is we're also looking at, the model health system. How can we support our systems? How can we support our organizations in terms of the data they need in order for them to use to understand and to benchmark their performance in terms of why people leave, in terms of their numbers, in terms of, for example, sickness records, in terms of vacancies. How can they use data to inform as they plan their improvement plans? And we've got a model health system. And if colleagues need support with that, we are more than happy to provide more information on how you can access the retention compartment in model health system. The last bit I'll just talk briefly about is around the research we are doing in the national program. Research is important, and we'll have colleagues later on who talk about some of the research which is going on across the country to try and understand exactly what's happening for our staff. And we want to use that evidence to improve the program. We want to be informed by the evidence on some of the interventions we are doing in addressing the challenges around our workforce supply and how we retain our staff. The last bit I'll just touch about is obviously people, you might be wondering, this was a quick rundown of what we are doing. How do you know more about what we are doing? I know colleagues will put some information on our in the chat box in terms of the retention hub, where you can find some more information about some of the work we are doing in terms of retaining our staff. But for now, I just want to say from our program, thank you for you guys actually for coming, because this shows how much you're interested in this piece of work we are doing. And, my first opening line was, we are focusing on people. We will always need our people. And if we can focus on each individual who work for the NHS, then we can hopefully give our NHS people a better experience, and they'll stay and support us as we recover from this pandemic. Thanks, Zoe.
Thank you very much, Chris. Really, really good to hear all the good work happening out there that supports us on the ground. Can we have the next slide, please? And we'll now hear from Dr. Andrew Wayman. Dr. Andrew Wayman is a principal investigator, ESRC Research at University of Bath. Welcome.
Good afternoon. Can I have the next slide, please? Thank you. What I want to do this afternoon is talk a little bit about some work which, as has been said, was funded by the Economic and Social Research Council to look into the issue of staff retention and in particular the impact of COVID on staff retention in the NHS. The research team is myself, Deborah Roy and Peter Nolan, who previously done work on staff retention in the issue relating to the rise in pension age a few years ago. So we've worked together for a while in this area. So in many respects, this current project builds on our previous work. Rachel O'Hara and Joanne Costu and I have also worked together on looking at ambulance issues, and Richard Glendinning, former director of GfK National Opinion Poll, and Rachel O'Hara and I also go back about 20 years when we previously worked for the HSE before entering academia. So a bit of background on who we are, I guess. So to say a bit more about the actual project itself. Next slide, please. Okay, so what we're about is trying to answer what we believe to be three key research questions. The first of which being, how will the COVID pandemic impact on staffing resources in the short and longer term? We also obviously want to look at what the impact will be, or the legacy of the crisis will have on the resolve and capacity of current employees to remain. And I think at this stage, we don't know for certain the extent to which the COVID experience will strengthen or weaken, or the experiences will strengthen or weaken people's resolve to remain. And ultimately, we want to know more about which variables predict exit or indeed remain in the working for the NHS, and also something more about the employment destinations of those who leave the NHS. So not just people that move around within the NHS, but those who actually leave for alternative employment. Next slide, please. So the way in which we're approaching this is to use three complementary data sources. There's some empirical and some secondary sources. So we've got a social survey, which is in 2 waves. And the first wave went out in December and early January. And this was basically a survey to try and explore the issues, but I'll give you some examples of the sorts of things we're exploring in a moment. This used the YouGov panel as the sample, so to derive a sample from the YouGov panel. YouGov have about 1 million people on their panel. And obviously, because the NHS is such a very large organisation, then it's relatively straightforward to come up with a robust sample of a couple of thousand NHS employees. So the first wave was based on that panel alone. The second wave, which has just begun, is a repeat of the YouGov panel. So it'll be at least half of those people who answered the first wave will be after the second wave. So we can look at whether people changed their attitudes and orientation and their behaviour over that period. But it's also going to be a larger sample. Rather than 2,000, we're going to actually try and distribute the survey. We are going using RCN, the midwives, physiotherapists, Unison, and a sample of 8 NHS trusts to generate a much larger sample. So we should have a sample of around, we think, 6,000 or 7,000 individuals. So that's all occupations, all grades, professionals and non-professionals across the NHS. In addition to the social survey, we're also doing some case studies. So this will involve looking in more depth at a sample of trusts. So 6 trusts we've got signed up to do this. So we've got acute, ambulance, mental health and community, again, trying to get a fair bit of breadth there. And this will take the form of qualitative interviews with a cross-section of staff in each. And again, really the point of doing this is to find out what people's experiences are and how that translates and which issues are important to them and so forth, to triangulate, we would say as researchers, on the evidence we've got from the social survey. We're also doing some secondary data analysis, and we're going to look at the National NHS Staff Survey with several waves, but also the National or the UK Labour Force Survey. And one of the reasons we're going to use the Labour Force Survey data is because the Labour Force Survey allows us to track individuals over an 18-month period. So we can find out who is leaving and what the patterns of migration might be from the NHS and which sectors people might migrate to. And again, so it's which occupations, which grades and so forth, and at what age and so on. Next slide, please. So the idea is to try and put together a picture from what we've got here. So the social survey tells us quite a lot about what's important. It's about who these things are important to, and whether these profiles might vary by who, in the sense of not as individuals, but in terms of who you are in terms of your occupation, your grade, your ethnicity, your age, and so forth. Whereabouts in terms of geographically, and how many and how much. It tells us something about what's important and whether the profile of important variables or variables have an impact on people's well-being and their disposition to remain or to leave, and tells us something about, is that picture the same across the whole of the UK? Is it the same across all different professions and so forth, or does it vary demographically? And knowing if it varies demographically is important, obviously, because it gives you a clue as to where you might want to intervene, where you might want to actually get the most, which are the issues which are the glowing red, if you like, which require the most attention, which maybe should be top of the list for intervention, and which groups are affected by that. The interviews, the main purpose of this is, as I said, the social survey tells us how much and where, but it doesn't tell us very much about why, how, and in what way these issues that we might identify are important. So having qualitative interviews, getting feedback from staff and their managers, tells us more in terms of clues as to what might need to change or what might to be enhanced in some way in order to try and redress vulnerabilities, if you like, to resilience of NHS systems rather than individuals. And as I said, the secondary data analysis tells us something about the destinations, employment destinations of leavers. Are they moving off into private sector healthcare, for example, or are they moving off into other areas? And we do know, for example, that those profiles do differ quite a bit between different professions. So our suggestion is that what we're trying to generate here is policy relevant evidence, if you like, which relates to, is relevant to NHS resilience. As I say, not in the sense of resilience of individuals, but in the sense of resilience of organisations to actually continue to provide care to the public. We're also interested in employee resilience and well-being, again in the sense of, what are the kind of corrosive elements, if you like, which may start to erode people's well-being, and to the point where that may impact upon their capacity to, in terms of their health and also their capacity to remain. And again, in terms of intervention, what we're suggesting here is, if you have this more granular approach, hopefully putting the data together will tell us a bit more about whether what's needed here is a one-size-fits-all, if you like, for all staff, or is it certain groups are more vulnerable than others. Next slide, please. So just to give you a bit of a flavour, I can't talk you through all of the issues we're exploring, but I'll give you some examples of the sorts of things we're exploring. So we've got 3 or 4 slides on this. So one of the things we're asking people about are the areas which I guess are intuitive, things like workload, working hours, job satisfaction, people's health status in terms of mental and physical health, the level of support from their colleagues, their managers, their employer, and the recognition from the public, how they perceive the recognition from their employer and for government. So asking people to say, well, but how does the situation now compare with the situation before March 2020? And I think in many respects, the issues we're identifying here are perhaps issues which are not necessarily new issues, but we suggest may have come into sharper focus as a consequence of the unprecedented pressures associated with dealing with COVID-19 and its broader implications. Next slide, please. One of the other things we're exploring is to ask people about issues that they're worried about, if you like. So a whole range of issues about how much of an issue of a worry is a certain issue for you. And again, looking at things like impact on mental health, being redeployed. We know that certain groups have been more deployed to work with COVID patients and others haven't, for example. And the idea is that we're going to interrogate the data set to see whether the kinds of the experiences of individuals and their orientations, the level of worry, are these variables which predict people's propensity to leave or to stay for that matter. So other examples here, being given too much responsibility, being asked to do work I've not been trained for, the effectiveness of PPE, and so on. I mean, one of the things which I'm able to share at this stage, because we have got some findings, but we haven't put them in the public domain yet, but I think it's fair to say that when we actually look at the proportion of staff, we find quite widespread worry over these kinds of issues. But we actually look at the proportion of staff that are reporting these concerns to their line manager, we actually find there's actually, well, there's a large figure of underreporting, shall we say. A lot of the stuff appears to be under the radar. and that in terms of organisational learning, if you like, is potentially problematic. Next slide, please. One of the other things we're doing is to try and get some kind of indication of people's intention to leave the organisation. And this is a tricky area in the sense that it's difficult to, when you ask people about the future, quite often our aspirations, the things we'd like to do, don't come to fruition. So one of the ways we've tried to take account of that is to use a technique where we sort of got like a ladder almost, or a staircase, if you like, which shows different levels of commitment. So we're asking people about, have you simply talked to colleagues, like most of us do from time to time, about how the job opportunities elsewhere, or I'm fed up with this job, I want to move on. But actually looking more detail on that, how many have actually looked at the vacancy list, how many requested details for a job, or submitted an application, or were interviewed for a job, and so forth. So what we're trying to do is get some kind of indication of the strength of this kind of commitment. And again, looking across the different demographics, structural demographics within the organisation, to see whether these issues are stronger or weaker in terms of certain demographics compared with other demographics, and equally able to compare whether this profile is changing or not between the data we got back in December and the data that we're gathering at the moment. So next slide, please. Another issue that we're doing is to try and get some kind of indication of the relative importance of what we might call push and pull influences. So influences that might encourage people or motivate people, or people feel that they need to leave the organisation, or influences that might enable people to stay in the organisation. And one of the things we're trying to use is a rather more sophisticated than normal system for ranking that, so we can actually look at how much more important one variable is above another. So the variables we've got listed on the right hand side there are the sort of things we're looking at. So we've got time pressure, working hours, work-life balance, and so forth, the usual kind of suspects. We're trying to pull out which of those variables, how do those variables of the rankings vary, how much more important might one of those variables be than the next variable in our ranking, and of course, are the rankings the same across all groups of staff, all demographics, all age groups, different ethnicities, regionally, and so forth, or is it a unified picture of the UK, or does it vary by different segments? And again, the point being that recognizing that different segments perhaps of different issues tells you something about how you might want to intervene and with whom, and what the priorities for that might be. Next slide, please.
Andrew, I'm sorry to interrupt your flow. We just got about 3 minutes left, if that's okay.
That should be fine. Okay, so just to give you an idea of the profile of the sample, so the sample then is all NHS. So it's not, so what we've attempted to do is to weight the sample, so the sample gives a representative view, then if you like, which takes account of the relative size of the different populations. Okay, next slide, please. We've also got some interviews with staff, with case studies. As I said, we've got a vertical cross-section. So this is much more important. The quality of stuff is very much these interviews to try and find out what needs to change and in what way. So rather than just being able to get the data on how much, it's important to understand what needs to change and how these variables are important. So that's role. And the next slide, please. And as I said, with secondary data sources, the labour force survey we actually think is quite useful in the sense it allows a nationwide picture of the patterns of migration, and also shows, for example, the slide on the right hand side from our earlier work. We know that a high proportion of staff leave in their early to mid 50s. We also know that the NHS is quite an old and ageing population. The average age is about 44. So if that profile of exit in the early 50s continues alone, then those two, the rising age will coincide with that on itself as an issue within the next 5 years, or maybe 10 years or so. So one of the things we can do, they say something about where do people go, and we know something about the kind of levels of exit and how that might vary. Next slide, please. So what we're doing then is, I would suggest, a sort of a more epidemiological perspective. The kind of perspective we're looking at, we're not looking at individuals as such, we're looking at systems. So we're trying to understand what the profiles of these variables. We recognize, I think, most of what these variables are, which are important, but do they vary across different demographics? So for those of you who are familiar with things like workplace health and safety climate measures and the health and safety executive stress management standards perspective, it's much more aligned with that kind of idea. So it's really about who are the vulnerable demographics, if you like. How can we understand the importance of recognised drivers of exit, and which variables might encourage staff to remain, and really to try and sort of add extra insight here, which is relevant to interventions about how to enhance staff wellbeing and enhance retention rates, and critically, whether different answers are needed for different demographics. And the next slide, please. Right, so in summary then, where we are at the moment, we've done the first wave of the survey. This is completed in January. Wave 2 is underway, started literally about a week ago. The case study interviews are also underway. We've done about 20 or 30, I think, at the moment. And the secondary data analysis is also underway. So we should be reporting our results and ready to disseminate findings by late summer, early autumn this year. Okay, I think I'm probably out of time for that.
That's fine. Thank you very much, Andrew. A lot of us will be really looking forward to getting the information from the survey. We are all dying to know what we can do differently. Thank you very much for that. Can I have the next slide, please? We are now going to hear from Guy and Dr. Katie on supporting health and well-being, choosing to stay. A really very important element as well on retention. Welcome, Guy and Katie.
Thank you very much. So first slide, please. Thank you. So we called this choosing to stay. John used the phrase earlier. We think that's a probably more achievable goal than stopping people leaving. It's just trying to do the best for people that we can, staying well, as the phrase goes. So this is us, North Bristol NHS Trust. We are, as you can see there, 12,000 staff. Those are the kind of activity levels that we have during a normal year, of course, which is we've had anything but we're basically we're a busy 24/7 acute trust. Next slide, please. And we're in a much better place now, but we've had a very difficult past. So we had a sort of triple whammy. So back in 2014, we had 2 hospitals merge onto our Southmead site. CQC came along and not only told us that we required improvement, but really stuck the knife in, saying that our plans were not realistic, which was absolutely fair at the time. And then the third part was we were put into financial special measures. So very difficult situation. And the approach, I guess, that we were most used to and the approach that we took was a kind of command and control. But then we hit winter 2017, 2018, which was really very much our low point and the point at which we had a bit of an epiphany. So next slide, please. I mean, we look back at this now, the pressures that we're under and the COVID on top of it, and we think, well, what did we know? But really for us, this was probably about as bad as it got, actually. So our staff were not talking to us, they were talking to the press. You can see a couple of examples up there on the screen, and I guess the thing that epitomized it for me anyway was looking at the staff survey results and discovering that in that ranking of 116 acute trusts at that point, we were the 5th worst in the country for that question. Next slide, please. So we had a turning point, and the board, the whole organisation really were committed to making sure that we didn't go back to that place and that things really changed. And quite a bold statement I think we made at the time was to say that to staff that your health is as important as our patients. And from that starting point, we built a very comprehensive programme. We've developed it on since, but lots of interventions at that point. So, and it had a great effect. So we did see our sickness absence going down. We saw engagement increasing, and we saw the CQC come back and rate us as going from required improvement to good. A lovely little comment saying, with a strong focus on staff wellbeing, all staff felt supported and valued despite the significant pressures of the job. We won some awards as well, and I guess the icing on the cake was in the last staff survey we had done considerably better over those few years, so 21st best out of 128 acute. So still a lot of interventions, but we have, I think, a really good reputation now. So we hear anecdotally of staff coming to us and choosing to come to us because they hear that we care, and I think increasingly are choosing to stay as well, despite the pressures. Next slide, please. So I'll hand over to Katie in a minute, just to kind of outline a couple of cases and the sort of approach that we're taking. But really, an approach that many of you will be familiar with, that pyramid of a tiered pathway of support with the day-to-day stuff, the most important stuff at the bottom, the principle that most people will be okay most of the time with lots of stuff if we give them the support, and that kind of resilience being between us, not just an individual thing. And we do that across 3 themes, which I'll ask Katie to talk through now. Organisational care, self-care and team care.
Thanks, Guy. So as you can see, yeah, we've been busy, and more recently we've tried to focus on team and proportionally moved the shift away from one-to-one sort of psychology, which is what we started doing primarily. So as you can see, there's a lot there under team care, and we've been working hard to encourage teams to kind of shift the culture towards a more compassionate, peer-to-peer, looking out for each other, a healthier culture. So some examples of these, of me and my team, which we'll talk about in a bit more detail later. Start Well, End Well, which some of you might have heard of, because we've done a webinar for NHS people on that previously. This is about checking in and with each other at the beginning of shifts, so separate to a clinical handover, and encouraging anyone to be able to facilitate a peer-led pit stop, which is a moment to take stock and check in with each other. We've been developing our trauma pathway, so as part of that we've put together some trauma awareness training, so psychoeducation around trauma, but we're also sort of adapting our peer-to-peer trauma support network, which was previously outsourced from March on Stress, something called TRIM, which you may have heard of. We've realised that we can adapt that to better suit the needs of an acute hospital setting, so that's something that we're working on. Okay, next slide, please. So I'm just going to move on to just talk about a couple of case studies to give you a flavour of what we've been doing. So this is a piece of tailored teamwork. So we had a request from a senior consultant in the emergency department, and sadly a couple of years ago they had a junior doctor commit suicide, and this consultant, who had taken an interest in wellbeing, was wondering whether the team were doing enough to make sure that something so tragic didn't happen again. So they came to us, we considered the request, and actually we felt that we could offer something a bit more bespoke, something to fit their needs better. So I liaised with the psychologist who is a bit more embedded in ED, with the consultant and a senior ward sister, and we kind of got our heads together and decided that instead of just a one-off training package, we wanted to deliver something that led to more sustainable change. So again, thinking about the cultural shift. So myself and the other psychologists developed some training which hit the criteria in terms of they wanted some top tips, and they wanted some psychoeducation around managing distress and dealing with just how to look after people, how to have those difficult conversations. So the outcome of this is that we've been running the training regularly, but in addition to that, the feedback and ideas that the groups bring anonymously, that gets fed back to a working group within ED, and they consider the feedback and ideas from the people that attend the training, and then they think about how they can implement those changes day to day into the team. So instead of us just focusing on the consultants and other senior doctors that supervise the junior doctors, we felt that actually, if we really want to foster peer-to-peer support, it's important that we include all staff groups, and that's worked really well. And in addition to that, ED highlighted that they felt quite separate from the rest of the hospital, so I think it's helped them recognise the other bits of wellbeing support that we offer, such as ACT courses and mindfulness sessions and the trauma focus one-to-one that we can provide in-house. Okay, next slide, please. Okay, and this is a case study of some one-to-one psychology from someone who may have left the trust after something that was quite a difficult experience for her. So unfortunately, a patient died, and the consultant was really struggling to cope with this after this incident. She was signed off sick. She was struggling to sleep. She felt she couldn't make decisions, and she was worried that she might have post-traumatic stress disorder. And she just felt, I can't be a surgeon any longer. So she came to see me, and we did a trauma-based intervention called EMDR, and we made sense of some of her struggles around perfectionistic tendencies and feeling not good enough, and made sense of where they might have come from and how to manage that. And I'm pleased to say she did a phased return, and she's back to work and enjoying work, and her confidence has definitely improved over time, and she's an advocate for well-being, which is great. Next slide, please. Okay, so I said I'd just mention me and my team. So this is a package that the psychology team put together in wave 1, and we cover 10 themes. We've slightly adapted it recently just to reflect the different stages of the pandemic, and like someone said earlier, just focusing a bit more on recovery and restoration. One of the main themes is around psychological safety, so thinking about how we can support leaders to support their team, and giving them a bit of space to reflect on what their team values are, but thinking about, ideas around how they can increase and foster psychological safety within their teams. Again, a bit around trauma, just making sure that they're aware of the trauma network within the trust, and that they know that people can be directed through that pathway to specialist interventions if they need them. Another thing that we cover in me and my team is, sadly, like many other trusts, we've had some staff die of COVID, and we really recognise that managers really kind of felt a lot of pressure and struggled to know quite how to manage something so tragic, and wanted a bit of support there. So we actually put a bereavement pathway for when a staff member dies. So we go through that within the training. So sometimes we deliver me and my teams one-on-one, but we also deliver it, say, for example, to groups of Band 7 nurses, to just what works best for them, really. So this has been, the uptake has been really good for this, and the feedback we get has been positive. So we'll be going through this, me and my team's package, in a bit more detail on a webinar with NHS England and NHS Improvement on the 28th of July, if anyone's interested in a bit more detail. Thank you. Next slide.
Thank you. So the amazing work that Katie and her colleagues have been doing is really sort of pushed a little bit more to that focus on teams, the focus on culture, the way that we do things. And we're really trying to, whilst the interventions are there, focus on trying to develop a wellbeing culture. And I think we are really starting to see that. So just a couple of things that have happened in the last couple of weeks. Had a conversation with EPRR manager, so emergency response, about the COVID boosters. And she came to me to say, and this is not necessarily the sort of fluffiest of professions, but she came to me and said, look, we've got 15 minutes with staff where they're sat down, not able to go back to work. How can we make that a really good wellbeing experience for people? And another example, we just now looking at linking Datix to wellbeing support. So if somebody fills in an incident, they can tick a box, and that then pings Katie and her colleagues, who can then offer direct support. So these things are just sort of popping up that aren't initiated corporately. They're just being created within the organisation, which is fantastic. I think you see the quote there, just want a dose of reality, really, that workload is a huge issue, continues to be for our teams. And I think that's why it's more important than ever to focus on teams, to focus on managers, and that integral support rather than interventions. And the final thing I just want to mention, you can see lots of happy pictures there. It takes bravery sometimes. So we ran an MBT Festival of Wellbeing during the 1st to the 5th of July. We were in internal critical incident stroke Opal 4 black alert at the time. It would have been the easiest thing in the world to stop doing it. And but I think it's such an important thing to continue to sort of support people when the times are toughest. We had a great response. We had letters of appreciation postbox. We had over 500 of those from colleagues to other colleagues, which left a really great feeling. And that's it. Final slide. Thank you.
Fabulous. Thank you so much for all of your well, everything that you've done and for presenting it to us as well. And I can see from the chat that there's lots and lots of support for what you've done and some questions as well. So massive thanks to Guy, Katie and Andrew and all of our speakers today. We've just got 2 more slides for you. So if we just move to the next slide, and the next slide after that would be great. 1 more for me. So we'll put a poll up and we'll leave the slide here. We'll put a poll up. So to what extent has today been helpful to you during and beyond COVID-19? So let us know via the poll and tell us to what extent has today been useful to you. And if you want to leave any comments, then please do in the chat room. So they're coming in now, which is fabulous. We'll keep that running. And just to let you know about our next session. So the next session is, as we always do, it's the second Wednesday of every month. And it is all about supporting the mental health and well-being of our people. So please do join that session. We're going to have lots of fabulous speakers like we have today. And we're also going to be talking about these mental health hubs that John mentioned at the beginning of the session. So thank you ever so much for joining us. We'll close the poll now. And please do add any of the any comments to the chat room as well. So without further ado, thank you so much for your time today. And we look forward to seeing you next month, Wednesday, the 11th of August. And we're going to be talking about supporting the mental health and well-being of our people. Take care, everybody.